Okay. We have a question for Jeff and Intellia. This is from Edie. Will Intellia accept patients for their clinical trials who have participated in other clinical trials or have been under drug treatment?
Right now, the way the trial is written is that it is looking for people that have limited or no access to some of the therapies that we've heard about today. So both the stabilizers and the silencers. So right now we are looking at kind of that untreated patient. We are looking at considering stabilizers in expansion, but that I don't want to speculate to some of the things that we've heard today. If someone, there was a question though, it was almost a two-part question, Muriel. The first part was if someone was on a clinical trial, I assume they mean that they have now completed the clinical trial. You know, if they were completed the clinical trial and they met the entry criteria, they certainly could make it. Participation in 2 clinical trials at once is something that we would not currently allow.
Okay, I have a question. Actually, I found, Jeff, that you raised more questions for me than I thought. At what point are you editing the gene? Are you doing it when someone is first diagnosed before they're symptomatic? Are you doing it while they're symptomatic? And does your editing of the gene, did I hear right that does not mean that they cannot pass it on? They can still pass on the defective gene to their children? I mean, I'm a little confused on that.
So there's 3 questions there, right? Okay, so let's tackle them, right?
I'm hoping my brain is like an explosion in a spaghetti factory, so just bear with me.
Okay, no, so again, when we look at the editing where it's taking place, it is taking place in the somatic cells in the liver, okay? So the genetic passage will take place in not from those cells, okay? So the germline editing is where you know, that would take place. So the germline cells, the cells that lead to the generation of the newborn, those would not be, it would not be passed on into the germline cells. So you will not pass these on to the next generation. Could you repeat the first 2 questions? I'm sorry, Muriel.
Oh God, you're asking me to remember my own question. Where are you cutting it? Are you cutting it when they're first diagnosed or when they're symptomatic, or?
Well, you know, I think that when it comes to a number of gene editing therapies, this is kind of now moving into, from a scientific space, this is my personal opinion, into an ethical space. Right now, it's interesting, even power of this technology to call it a drug, I think, but it does fall into a classification of a one-time treatment. Right now, the study design is looking for people with mild to moderate symptoms. It is not looking for people that are specifically just have the genetic diagnosis, but no symptoms yet. I think that is an ethical space with all gene editing, whether it's this type of disease or other diseases where we know the mutation is there, but maybe the disease is not manifested yet in this form of signs or symptoms. That is something that we'll tackle, I think, as a collective human group together as these technologies move to approval. Then the question is, when should we ethically allow that this type of therapy be implemented?
Okay, and I want to get this clear, okay, because I'm a little thick. So if my mom had Intellia treatment and she is now quote unquote cured, does that mean that you know, before and now she makes a baby, does the baby have a chance of getting TTR, or
yes.
The baby, yes, so it doesn't help the future generations? Okay, I want to make that very clear for everyone. Thank you.
No, I'm glad that we were making it clear for everyone. Okay,
super. Next question. Okay, this is from Conrad. Which pharma companies are willing to participate in an explorative inventory study to examine whether the combinations of a silencer and stabilizer creates, we discussed this already, so never mind. Okay, Ernest, as a long-term LU58 HIS mutation, I am aware of the numerous metrics used to determine ATTR-V disease staging in the clinical setting. I have my own hypothesis, which answers the questions below. We'd like to hear from you. Okay. With respect to the ATTR-V disease staging, stabilizers, and silencers, when does one start stabilizers? I'll read them all and then you can see where it's going. Question 2, ignoring side effects, when does one stop stabilizers? Question 3, when does one start silencers? Question 4, ignoring side effects, when does one stop silencers? As a corollary, question 5, when does one start stabilizers and silencers in combination? And question 6, ignoring side effects, when does one stop stabilizers and silencers in combination? I guess getting down to it, this last question actually is something that we've heard from other people as well. Does one ever have a chance to stop stabilizers and silencers? I don't see, based on what limited knowledge I have from watching all of you, that that would ever happen. It looks like it's going to be a lifetime that you take this. Am I wrong?
I mean, I think just answering for, our work at Alnylam, and we obviously deal with silencers, drugs like Onpattro. If you're reducing the level of the disease-causing protein, the pathogenic protein TTR, then as long as you and your doctor agree that you're getting benefit, then you would stay on that drug. Now, decisions about being on a treatment or not being on a treatment are always very personalized, and physicians have to work with patients to determine that. But that's the best answer we can give, having developed the drugs. Ultimately, each patient is different, and their doctor would help them with that decision, I should think.
That makes sense. Anyone else want to comment before we go on? Okay.
Go on, please.
Oh, no. From Karen. Hi, my digestive system has been impacted with amyloidosis and I have issues with absorption. Does this impact the delivery of my medicine, and is one form of the tafamidis better than the other under these circumstances? Adam? Okay. Is anyone else here from Pfizer? All right, let's ask Dr. Karam. Dr. Karam, what do you think?
I think that's a great question. And definitely, if you have amyloid deposition in the GI tract and the transit is either accelerated or impaired, you may have issues with absorption. So that's definitely something that could be problematic.
Okay, here's another part to her question, and maybe you can help on this, Dr. Karam. Do biologic drugs such as Facendra, F-A-S-E-N-R-A, interfere with the way the stabilizer or silencer drugs work?
Sorry, can you say that drug again?
I'm not familiar with that drug.
Facendra, F is in Frank, A, S is in Sam, E, N is in Nancy, R-A, biologic drug. I don't.
Yeah, I'm sorry, I'm not.
Oh, okay. It's a drug for asthma, benralizumab. So it's probably anti-IL-5, I think.
Oh.
Yeah, I don't think it should be interfering with the drugs that we're using for amyloidosis.
And I can speak at least for Onpattro, it wouldn't interfere with Onpattro.
Okay, this is from Miles. Regarding wild type ATTR, are there any recent evidences that, okay, he's combining, okay, sorry. Okay, here's Jeff. I've been on tafamidis for 1 year now. I'm feeling better, probably mostly due to the torsemide diuretic. Going forward, what testing is indicated to check on any improvement in heart function? Well, we've heard about NT-proBNP. Are there any other things we do to check to make sure the heart's improving? Cardiologist?
So is Natasha still here, or do,
Brett Sperry, cardiologist. I don't, Brett, are you here? Okay.
I think Muriel, if the cardiologists aren't here, what we can say from the various biopharma companies, I'm sure others would agree, there are a lot of imaging modalities. Dr. Wall maybe can even speak to it. A lot of imaging modalities are being used to evaluate the load of amyloid on the heart. whether that changes over time. And I think people are interested in things like the technetium scan or more sensitive ways to look at the amount of cardiac amyloid in the heart. So MRI, cardiac MRI is the latest sort of thing that's being considered. It's investigational right now. It's not routine in every hospital. We've done a little bit of work with that, and there's a group in London showing some recent evidence that looks interesting of reduction in cardiac amyloid load with Onpattro. I'm sure other drugs are being evaluated similarly, but it's that imaging frontier and other echocardiographic frontiers that will be useful in determining cardiac function.
Yes, and we saw that Dr. Wall mentioned he had a patient that where the NT-proBNP and his imaging, that they were not in agreement. So I found that interesting. So
yeah, so that actually, that's right. That, you know, I mean, again, Dr. Wall should speak, but it sounds like his technique is more sensitive than looking at a blood marker like the NT-proBNP.
So will you be watching more of that, Dr. Wall?
Yeah, we've actually we just submitted an abstract actually to the ACC about the first analysis of the correlation between NT-proBNP in our AL patients and TTR patients, and I won't spoil it for everyone, but it's
you can.
It's very different between the two, and I think what we think we see is that the amyloid load in AL patients is reflected by the NT-proBNP, but in TTR patients it's more complicated, and that it isn't. And one of the things we've been thinking about is that maybe it's more than just the amyloid load that affects the cardiac function in TTR patients, because you have this other thing that we haven't talked about today, but the toxic oligomer. So TTR can form small fibrils or small aggregates that are toxic to cells, and they could be impacting the heart as well. And they're technically sort of not amyloid fibrils or amyloid deposits. So the TTR, the way the TTR amyloid affects the heart in these patients is complex. And so we have some data on that, and we will look into it, because I think it's an interesting biology question and a disease understanding question, because we're still trying to understand a lot of this, I think.
Wonderful. Okay, here's another cardiac one. I see Dr. Sperry is back with us. Okay. I have been diagnosed with ATTR wild type condition affecting the heart. I am male, 80 years old. I also have a history of bilateral lower back pain. In my 40s, I underwent carpal tunnel relief for both hands. Wow, he probably had it for 40 years. Wow. Are any tests for my hands or back available to determine if the amyloidosis condition is the cause? So can he go back 40 years and find out, you know, what was going on, Dr. Sperry?
Well, so I mean, we do see people with a significant lag time with the orthopedic manifestations, 5, 10, 15, you know, even longer years. And the issue with the orthopedic manifestations are they're very common in the general population, and so so you know you'll never really know, especially if something has happened that long ago. Whether it's related or not. Normally we see 5, 10, 15 or so years beforehand. But maybe Dr. Karam can speak to it, but I don't know of any specific way that we can definitely know, besides biopsying the carpal tunnel or spinal canal or whatever during one of these procedures. I know Dr. Wall's images are able to, in some patients, see uptake in the back and in the spine, which we think might be infiltration in the ligamentum flavum and other areas. So so that may be a way as well.
Yeah, I agree. So just to expand on this, carpal tunnel syndrome is very common in the general population. So it's estimated between 5 to 10% of people with no history of amyloid and who will never develop amyloid will develop carpal tunnel syndrome. And if you look at specific population like diabetics or people with what we call Charcot-Marie-Tooth, which is a group of inherited neuropathy, not necessarily amyloidosis, the incidence of carpal tunnel syndrome increased to 30%. So without a biopsy, it's really hard to determine exactly whether the carpal tunnel syndrome or the lumbar stenosis, etc., are actually caused by the amyloid or not. Now, hopefully, with the beautiful images that we saw with Dr. Wall, that issue would be resolved, but we're happy to look until we get more data.
Thank you. We don't have a GI doctor with us today, so we'll have you, Dr. Karam, play GI doctor for a bit. If anyone else knows the answers, feel free to pipe in. I was diagnosed with gastroparesis several years ago. I'm currently taking azithromycin for it. It seems to be working well. What role does Emmy play in the bloating and motility? I bloat daily and try to be careful with my diet as required for GP.
Yeah, so these are very common problems with people with especially ATTR and AL. Not really sure about wild type, but in general, we have to treat those symptomatically. And with the treatment, we've had success with the silencer. I'm not gonna specifically say names, but the silencer, we've seen people improve from their dysautonomia, from their GI tract. So it's a combination of pro-motility drugs that the GI doctor or the neurologist who has some experience with it can prescribe, and of course treating the reason why people have the disease, the cause of the disease, can help these patients.
So
These patients have GI involvement because of autonomic neuropathy or because they have amyloid in their gut?
it's both.
Impossible to really answer, but it could be both. In general, it's probably both. The amyloid can deposit in the intestine, and a lot of time on biopsies, we see amyloidosis, but also the amyloid can deposit in the autonomic nervous system and cause dysmotility. So this is a difficult question to answer, really.
Yeah, I mean, I would just add to what Dr. Karam said, Muriel, that certainly, when he talked about silencers, we had looked at our data from the phase 3 studies of Onpattro and seen improvements in the autonomic features and in the gut features. And one of the sort of gratifying things was that patients, stop losing weight so suddenly, because weight loss is such a dreadful thing with HATTR when the gut is involved. And so that's been a good feature of the drug, I think. And obviously we hope to build on that.
And well, while I have all of you thinking this way, okay, we did get a lot of queries from our wild type people stating that they have neuropathy and they don't see neuropathy mentioned or associated with wild type. And of course, it's kind of hard to image nerves for Dr. Wall, I'm sure, but he'll work on it. But the thing is that, could we be closer to this actually being not necessarily one disease, but would we say that we're seeing neuropathy more with our wild type patients, and maybe we should close that gap a little bit?
Yeah, that's a great question that I honestly struggle. So I don't really have an answer, but I will tell you some statistics and we can go from there. So as people get older, the incidence of neuropathy becomes more common. So if you take people over the age of 60, around 10% will have peripheral neuropathy. And same thing with wild type TTR. As we get older, the incidence becomes more common. And another, to make things a little bit more complicated, spinal stenosis is very common and can mimic distal peripheral neuropathy. We have several factors. And, when you have patient with amyloidosis, especially wild type, you're going to look closer to see if they have neuropathy. So there's many different reasons why the number of neuropathy, or we're seeing more neuropathy in wild type. I personally have not had any nerve biopsy. I've biopsied a few patients and I saw some of them are actually on this call, so they can comment. But I've been looking for wild type amyloid in the nerve. I haven't seen it yet. And to my knowledge, nobody has seen it yet. But there are reports showing that there's increased incidence of neuropathy in patients who's wild type. So this is an unsolved question, and it's a great area for research. And hopefully at some point we will figure this out.
Okay.
Yeah, I would just like to add that, I think a lot of people with wild type have neuropathic symptoms, but it is a lot of it's from the spinal stenosis or the carpal tunnel syndrome, as opposed to true infiltration of the nerve.
Okay. Well, here's another one for you, Dr. Sperry. I get winded so easily. The lack of stamina is frustrating. I'm getting stronger with exercising, but I don't last very long. I get really tired after a bit. My cardiologist has put me in a referral for cardiac rehab. I feel as though I'd gotten really deconditioned. Do you think that the cardiac rehab will be helpful?
Yes, certainly if the symptoms are from cardiac causes, then there's a lot of great data for cardiac rehab showing improved quality of life, reduced readmission to the hospitals, even prolongation of life and decreased cardiac events. So if we're talking about cardiac problems leading to shortness of breath and fatigue, and you meet criteria for cardiac rehab, then yeah, I would definitely recommend cardiac rehab.
Okay, this is from Miles. Regarding wild type ATTR, aside from the hypertrophic cardiomyopathy presentation, I also have neuropathy in feet, ankles, hands, and wrists. Just what we were talking about. I received X-ray testing from rheumatology showing stenosis, but only slight signs of osteoarthritis in my right wrist. Is it worthwhile to spend time and resources to establish whether the neuropathy is definitely amyloid or arthritic in nature? Specifically, is there a non-narcotic treatment for wild-type TTR caused peripheral neuropathy?
I'm sorry, I was typing an answer and I didn't listen to the whole question. So wild-type TTR, I think, people, as we mentioned, we don't know for sure if it's neuropathy or spinal stenosis. Is there a reason to pursue it? I think it depends on the patient and their doctor. To me, it would be interesting to know exactly why somebody has neuropathy, because, people can have neuropathy from diabetes, from vitamin deficiency, from other causes, not only wild-type amyloidosis. So there's a reason. And if it's spinal stenosis, as somebody I just answered the question here, typical, people lean forward, it relieves their symptoms. That's a typical sign of spinal stenosis. And that could be, you can have intervention and surgeries to improve that.
Okay, Dr. Karam, is there a non-narcotic treatment for wild-type ATTR caused peripheral neuropathy?
Yes, so for neuropathy, typically we actually prefer non-narcotic because there's evidence now that the more narcotics you give to these patients, it's a short-term solution. And on the long term, people with neuropathy who go on narcotic do worse than people who don't go on narcotic. So the typical medication that we prescribe for neuropathy symptoms are the duloxetine, which is an antidepressant, nortriptyline, another antidepressant, gabapentin, which is a sodium channel blocker, and so forth. So there's many different options that your doctor, and we also have topical treatment. We also use sometimes alternative treatment for people who don't want to do medication, acupuncture, massage, and so forth.
I know the late Janice Weissman used to always stress at our meetings that alcohol was bad for neuropathy. So do you want to mention anything about that?
So being overweight, being sedentary, not doing any exercise, and alcohol itself is toxic for the nerve. I mean, that's it. So you have to limit significantly and even stop and cut down the alcohol consumption.
Okay.
I'm sorry to say that. I'm gonna have a drink later, but I'm sorry to say that.
Well, I'll drink mine now. No, okay. In August, I suffered a partial rupture of my left bicep tendon. I know that this is sometimes a symptom of amyloidosis. Can you explain the relationship between the disease and a propensity for bicep rupture?
Yeah, so the idea is that you have deposition in a tissue that is somehow elastic, and the protein that is kind of making it weaker and more rigid, and that's the reason why you get rupture of the ligament.
Okay, oh, here's an interesting one. Robert, I have wild-type cardiac amyloid. I was diagnosed 10 to 12 years ago. I currently take Vindamax, been on it since January 2019. I've developed severe neuropathy in both my feet. I've tried Cymbalta, gabapentin with nortriptyline, and they've not worked well for me. What do we know about medical marijuana and its effects on patients with amyloid?
Muriel, sorry, just before Dr. Karam answers that, it's 3:30 and I have to drop off. So I really appreciate the opportunity to participate today, and thank you so much for organizing this. My colleague, thank you. Steve Roblin, my colleague, still here, so he'll answer other questions.
That's wonderful. We appreciate your coming. Thank you so much.
Thank you, and thanks to the other panelists.
Okay, back to medical marijuana. Hi, Steve. Welcome.
Hey, everybody.
Okay, who wants to tackle medical marijuana? Well, what the House of Representatives just passed, said it was going to be legal, and now it has to go to the Senate. So, and I've read quite a few states now have it legal. So, so we don't have to deal with that, be politically correct about that right now. Let's just say, what do we know? What kind of results have you seen with medical marijuana and neuropathy? Dr. Karam, you're first.
I think, Muriel, that could be a great survey for you to do among our patients. So, probably some of you, and I see Briar ask a question here. So I used to work in Oregon, and in Oregon, medical marijuana was legal, and a lot of my patients would try it, for neuropathy, pain, etc. And this is not a regulated thing. So people would go to the person who sells, and they would have different CBD and concentration, etc. So it's really hard to say exactly if everybody's getting the same thing. Obviously, they're getting different brands and concentration and so forth. But some people swear by it. So it's really same thing with the drugs that we prescribe. I mean, we never know. I can prescribe gabapentin or duloxetine. I have no idea if the patient is going to get better. It's a lot of time it's about 30-40% success rate. So I think with CBD and medical marijuana, it's probably around the same. And I don't really see harm in trying it if it's legal in where you are.
Okay, and why don't you collaborate with some of the other people in this group, and we can do a study on medical marijuana, okay? And we'll put out the survey, and we'll see how that goes. We'll get IRB approval for it, and we'll just make a splash at the next ISA with the medical marijuana report. How's that?
It's a little bit complicated depending on the institution. If it's not approved on the federal level, you may not be able to do that. So it's a little bit more complicated than just doing this. But I think that's a very important thing to study eventually.
Okay, well, we'll have to watch and see if it's approved then by the Senate and signed by the president. Okay, so now what we're going to continue. We have a lot more questions, but I know we've got to hear from our clinical trial people. So we're going to take a 5-minute break, and then we will continue with the clinical trial presentations, and then we'll have more Q&A. So let's take 5.